Hey YouTube, welcome back to my channel. My name is Dr. Daniel Kaplan and my mission is to make psychology accessible to all. So in today's video, we're going to talk all about ADHD, Attention Deficit Hyperactivity Disorder. What we're going to learn is the three subtypes of ADHD. We're going to go through some groups of people have higher or lower rates of ADHD. We'll talk about some treatments for ADHD, and then we'll conclude with an instrument that is used to detect ADHD and some fairly commonly co-occurring conditions. So if you like what you have to see, hit the like button, subscribe, click the notifications tab so that you can have access to everything we're talking about today. So what is ADHD, or Attention Deficit Hyperactivity Disorder? It is a cognitive or a neurocognitive condition where children struggle with either inattention, hyperactivity, or impulsivity sometimes, or sometimes both. So there are three subtypes of ADHD, right? Inattentive, hyperactive, and combined. And we'll talk about all the features of each. But when we think of ADHD, the primary symptoms, they can feed one another, but there usually is one set of symptoms, or at least one symptom that stands out more than the other. And when it comes to ADHD, I said that there are oftentimes co-occurring conditions. So we see people with ADHD struggle with learning and communication. They might struggle with poor academic performance. They might have social and relationship issues with other children or friendships. They might engage in conduct problems such as defiance of authority figures, or may even do some more significant deviations from what is socially acceptable. And then it's possible to have mood and anxiety conditions, very common. And then in adolescence, we should add substance use, right? So these are very commonly co-occurring issues with an individual who has ADHD. Not that everyone experiences it, but knowing this is going to be important when we do a diagnosis. And I'm going to introduce you to the Vanderbilt ADHD scale, and you're going to see that we tap into these features so that we can either see, A, does the person have ADHD? B, do they have co-occurring conditions, right? So we want to have a good sense of what's going on with this individual. So in general, we know that assessing ADHD can be challenging. So ideally, we should be able to see whatever the inattention or hyperactivity or impulsivity, we should be able to see these symptoms in multiple settings, right? So it should be, let's say, in the home and in the school, or it could be any kind of multiple settings, right? And because of this, sometimes it's hard to assess because we don't always have access to what's going on in the school and in the home and what the child experiences. So we do have ways of tapping into it, but ideally we should get input or feedback from the child's point of view, from their parents' point of view, and from their teacher's point of view. Now, when we get feedback from a parent, a teacher, and a child, it is not uncommon for that feedback to be inconsistent. Sometimes we see that parents will minimize the ADHD-like behavior. Sometimes we see teachers will exaggerate or maximize the ADHD features. And sometimes the child will give you a rating in between. And knowing that you can have a teacher's report, a parent's report, and a child's report that's very different, we have to find a way to put it all together. We have to see. Now, one of the ways we assess are with diagnostic interviews, rating scales, which is something that I'm going to review. And we have more comprehensive psychological testing. I could give, for example, a psychoeducational evaluation, which includes an IQ test and perhaps an achievement test. And I could be able to detect certain areas of functioning that might indicate ADHD. But we typically can diagnose it without a full psychological test. So, what are the criteria? And I'm sorry that this slide is pretty busy, but there are 9 features of inattention, and there are 9 features of hyperactivity. In order to meet the criteria, in order to get this diagnosis, you have to have 6 out of 9 of the features with moderate severity or impairment or worse. So the 9 symptoms or features of inattention might be not being able to pay attention to detail, or frequently making errors, or they struggle with maintaining their attention. They might not listen actively when being spoken to. They might fail to carry out the instruction or complete their work. They might seem distractible or disorganized. They might not be able to manage mentally effortful work. So while things that are easy they might perform, when it comes to more challenging tasks, they might struggle. And you might see careless mistakes. You might see daydreaming. You might see them forgetting to do basic activities. So these are examples of inattention. And I'm going to show it to you once more in a different look with the Vanderbilt ADHD scale. Hyperactivity, technically it's hyperactivity or impulsivity, right? So we might see a person who fidgets a lot, taps their hands, or squirms in their seat. Sometimes they might not be able to stay seated, or they wander from their seat, or they might climb the fences of recess, right? So they might climb, or they might struggle with quiet time and blurt out something, or they might talk excessively or interrupt other people, might not be able to take turns. They might barge into other people's conversations. Now you'll see there's a lot there for inattention, and there's a lot there for hyperactivity and impulsivity. In order to meet the criteria, I repeat, for inattention, you need 6 out of 9 criteria. In order to meet the criteria for hyperactivity, you need 6 out of 9 of the criteria for 1B. Now, what happens if a person has 6 or more criteria met for 1A and 6 out of 9 of the criteria met for 1B? Well, we have something called a combined subtype of ADHD. So the 3 subtype: inattentive, hyperactive, or combined. Now, so that's 1A and 1B. We also need that these symptoms display in early childhood. So the symptoms should be present before the age of 12. Now, that does not mean that they are diagnosed by the age of 12. There are sometimes people go their whole childhood without a diagnosis, and then they get to college or they start working, and then all of a sudden the ADHD starts to surface. It is possible that the diagnosis didn't come, but the features, the symptoms, some of them at least should have been in full display even as early as elementary school, right? So we also want to make sure that this is not situation dependent. So we want these symptoms to occur in more than one setting, and somehow it's going to impair functioning such as their academic progress, their performance at work. It could interfere with romantic relationships because they're talking over their partner because of the impulsivity and so forth. So what's the epidemiology? The epidemiology is that we know that anywhere between 4 to 9% of children display symptoms of ADHD, and this is far more common amongst boys relative to girls. So we see about 70% of the cases are male, and we do see it runs in families. So if you have a child whose parents had ADHD, they're going to be more likely to develop ADHD because it runs in families. And as you get older, interesting to note, people start to have a lessening of symptoms. So as we move from childhood to adolescence to adulthood, people sometimes say, well, did I grow out of my ADHD? The answer is, to some degree, yeah, right? Because you learn strategies to cope with your ADHD. It's still there and it could interfere with your functioning, but through time, you learn strategies to navigate it and be able to function properly in the classroom, etc. And what we see, though, of this percentage, there's anywhere between 35 to 60% of people who are diagnosed with ADHD who continue to have it as adults. So the most common scenario is ADHD starting in childhood, continuing into adulthood. It is rare that we see ADHD just pop up in adulthood. Most likely the case was that they had ADHD, wasn't diagnosed, and the situation changed to the point where it started to become more of a problem. Now, so what are some of the causes of ADHD? We understand that there are biological factors. So if we think about the frontal striatal cortex, or that part of the brain, we have abnormal dopamine levels, right? So neurotransmission, chemicals like that we see. We also know that stress is a universal trigger to mental illness, and family dysfunctioning can contribute to ADHD. So that's ADHD, the 3 subtypes. Now, how do we treat ADHD? Well, what we see is that about 80% of children and adolescents who are diagnosed with ADHD, they receive treatment in one form or another. Now, there is an argument or a debate in the profession as to what the best course of treatment is. There are some people who want to prescribe a psychostimulant, things like Ritalin or Adderall. There are some people who say you can accomplish treatment for ADHD with purely behavioral therapy. And then there are people who say we should have behavioral therapy and adjunctive pharmacology, which is where I land. I think that the medication is helpful. So we really see that there has been a boom in medication and the prescription of medication. We have millions of children and adults on ADHD medication, things like Ritalin or Adderall. So if we were to look at it, like I said, there are many people treated with Ritalin, Adderall, Strattera, things like that. And the estimate is 2.2 million children, which is roughly 3% of all school-age children are taking some psychostimulant, whether it be Ritalin or something else. So there is, I said there's a debate, right? So there are some people who say the long-term effects of the drugs are problematic. It's going to cause health side effects. So we don't want these children on a medication. We also know that it is possible that there is an overprescription of ADHD medication. So there are some children who are receiving treatment for ADHD with Ritalin and Adderall that don't really need to be on it. So that is a problem. And then, these are people say, no, it's going to affect their organs. We have an overdiagnosis of ADHD. But through time, we've done research, and what we've found is that the medication is indeed effective and largely safe. So I know that we talk about drug holidays, taking your kid off the medication for a certain period of time and so forth. But overall, Ritalin and Adderall, there's fairly safe medication. But we usually put them in conjunction, and we typically have behavioral therapy as well. So we work with the child, but as with many childhood disorders, we have to wrap in other people. So we're going to work with a whole behavioral team, and that behavioral team is going to include the parents. So we're going to teach them strategies to help shape behavior. We're going to work with the teachers to help with classroom management. And what we found is these behavioral interventions in conjunction with drug therapy or pharmacotherapy has been profoundly effective. So that is my discussion on ADHD. But as a clinician, I always like to offer an instrument that you can use in your practice to assess ADHD, or if you're not sure if you have ADHD, offer a screening instrument. So let me pull that up and we'll continue. Okay, so I pulled up the Vanderbilt ADHD scale. Now, I pulled up a teacher informant. There is a self-report and there is a parent's version, but I think it's good to see the various ways we can assess. So let's go through the symptoms, and you're going to see the first 9 symptoms are for ADHD inattentive subtype, and then the second 9 features or symptoms are hyperactivity. So let's look at 1 through 9. We see fails to give attention to detail or makes careless mistakes on homework, has difficulty sustaining attention or tasks, does not seem to listen when spoken to, does not follow through on instruction or fails to finish homework, has difficulty organizing tasks and activities, avoids, dislikes, or reluctant to engage in tasks that require sustained mental effort, loses things necessary for tasks or activities such as school assignments, pencils, or books, is easily distracted by extraneous stimuli, and is forgetful in daily activities. Now, if we look at the rating, it goes never, occasionally, often, or very often. Of these first 9, we need 6 2s or 3s. So often or very often is a clinical threshold where it's concerning to us. And through 1 through 9, we need 6 out of them. If we have fewer than 6, we cannot diagnose ADHD inattentive subtype. So let's go 10 through 18. So we start to see fidgeting with hands or squirms feet, leaves seat or in the classroom when they're expected to remain seated, runs about or climbs excessively when expected to remain seated, has difficulty with doing leisures quietly, talks excessively, is on the go, keyed up, driven like a motor, blurts out answers, has difficulty waiting in line, and interrupts or intrudes on others, such as butting into their conversations or games. So you'll see 10 through 18, these are the hyperactive or impulsive subtype. So if you have 6 out of 9, right, with 2s and 3s, then you could diagnose ADHD hyperactive subtype. If you had fewer than 6, you couldn't. So let's say you had 6 inattentive and 4 hyperactive features. We would be required to diagnose that as ADHD inattentive subtype. If you had 6 and 6, then you would have ADHD combined subtype. But there are other conditions that tend to occur that coincide with ADHD, as we mentioned. A person loses their temper or refuses to comply with adults' requests, is angry or resentful, is spiteful and vindictive. These kind of features are very common in the case of oppositional defiant disorder, which is basically fighting against authority or rules. But we also have others that are more concerning, things like bullies, threatens, intimidates others, initiates physical fights, lies to obtain goods or to avoid obligation, is physically cruel, has stolen items of non-trivial value, destroys other people's property. These are a more severe conduct problem called conduct disorder. And that's when you violate the basic rights of other people, or in some cases, animals, right? Torturing animals as well. That would be conduct disorder. And then we have things like anxiety and depression. So things like being fearful, anxious, or worried, is self-conscious or easily embarrassed, afraid to try new things out of fear of making mistakes. These are anxiety symptoms. And then we have depression symptoms, feelings of worthlessness or being inferior, blames self for the problems or feels guilty, feels lonely, unwanted, unloved, feels sad, unhappy, or depressed. Now, if you go back to that slide that I listed, all the common features, over 50% of kids with ADHD had all these different things. It is possible for a person to have ADHD and depression and anxiety and oppositional defiant disorder and so forth. You can have multiple diagnoses. And why I love this instrument is that you can identify the potential for not just ADHD, but other things a child is struggling with. So that is the Vanderbilt ADHD scale. As I mentioned, you have a child version, you have a parent version, and you have a teacher version. I just went through the teacher version. Very useful instrument. So I hope you liked the video. As I mentioned, you should have learned all of the conditions or the features of ADHD, the 3 subtypes of ADHD being inattentive, hyperactive, and combined. You should have learned some of the risk factors for ADHD. You should have learned some of the treatments, and you just saw a screening instrument. I hope that you found this video useful. Once again, help me bring this video to a larger audience by clicking the like button, subscribe, notifications tab. That will allow YouTube to recognize its value and then propose it for other people looking for videos on ADHD. Thank you, everybody. Have a great day.